Welcome to this medicine masterclass on glomerular disease. Let's start by having a look at the various types of glomerulopathies that you may come across. Minimal change disease leads to nephrotic syndrome, and this is a triad of edema, proteinuria, and hypercholesterolemia. Edema occurs because as the proteins are leaked into the urine, oncotic pressure decreases, resulting in extravasation of fluids. There's increased lipids resulting in hypercholesterolemia, and on biopsy in minimal change disease, on light microscopy, nothing is visible. However, on electron microscopy, there is fusion of podocytes. Treatment is usually with supportive care to minimize edema, and usually patients respond well to corticosteroids. Focal segmental glomerulosclerosis presents with nephrotic syndrome, again with edema, proteinuria, and hypercholesterolemia, but in terms of the disease process, focal meaning some of the glomeruli are affected, segmental means within those some segments of the glomerulus are affected, and this is associated with HIV, Alport syndrome, but can also be idiopathic. On microscopy, there is an increase in hyaline, that's a pink material, and there's IgM and C3 deposition in the affected areas. These patients are treated with salt restriction and diuretics, antihypertensive and statins, and again usually respond well to corticosteroids, but in more advanced disease may require cyclophosphamide and cyclosporin, and if the disease progresses, may require a renal transplant. Membranous nephropathy. This presents with a nephrotic or nephritic picture. There are autoantibodies to phospholipase A2 receptor, and this can be associated with malignancy, secondary to drugs such as penicillamine or autoimmune conditions. In membranous nephropathy, there's a risk of renal vein thrombosis, which will result in a sudden deterioration in renal function. On biopsy, there is a thickened membrane, a thickened glomerular basement membrane, and a spike and dome appearance that is classically seen. IgG and C3 are subepithelially deposited. And again, treatment is with steroids, cyclophosphamide, or chemotherapeutics such as chlorambucil. IgA nephropathy, also known as Buerger's disease, or a synpharyngitic glomerulonephritis, presents usually with macroscopic or microscopic hematuria a few days after an upper respiratory tract infection or a pharyngitis. There is an increased level of IgA in the blood, and that forms complexes with the mesangial cells, and immunofluorescence shows mesangial proliferation with the deposition of IgA. Patients are treated with steroids, cyclophosphamide for more resistant cases, and blood pressure is controlled. Note that Henoch-Schönlein purpura is a variant of an IgA nephropathy, and this is associated with a small vasculitic process, and patients can have a purpuric rash on the extensor surfaces, typically of the legs and the buttocks. Post-infectious glomerulonephritis, this usually occurs weeks after the initial infection rather than days, and this can be secondary to virtually any infection. And light microscopy of the renal biopsy light microscopy would demonstrate proliferation of mesangial cells, neutrophils and monocytes, and they may have a recent infection, particularly a streptococcal infection, and that's why streptococcal titers may support the diagnosis. And treatment is usually supportive, and this tends to resolve. Mesangio capillary glomerulonephritis is a rare form of glomerulonephritis presenting with nephrotic syndrome. Patients present with edema, as well as hypercholesterolemia, and this is associated with hepatitis C. Biopsy shows a tramline appearance of a double basement membrane, and treatment is with corticosteroids. Anti-GBM or anti-glomerular basement membrane disease, or Goodpasture's disease, is an aggressive form of renal disease. This is an autoimmune condition in which antibodies develop against type 4 collagen, which is not only found in the kidneys but also in the lungs. So patients may present with hematuria as well as hemoptysis. This is a crescenteric glomerulonephritis, and immunofluorescence would demonstrate IgG linear staining for the glomerular basement membrane. Patients require very aggressive and rapid timely treatment with IVIG, intravenous steroids, or plasma exchange. IVIG are intravenous immunoglobulins. Another rapidly progressive glomerulonephritis is the presence of immune complex disease post-infectious or palsy immune disease, which is associated with Wegener's and Church-Strauss or Goodpasture, as we mentioned. And the rapidly progressive glomerulonephritis tend to demonstrate crescents on biopsies. And these require plasma exchange, IV methylprednisolone or intravenous immunoglobulins, cyclophosphamide or MMF, or more advanced treatment with the renal physicians. Now let's move on and talk about renal tubulopathies that result in acidosis. There are 4 key types: type 1, 2, 3, and 4. In type 1, there's a problem with the failure to excrete hydrogen ions, and so the blood becomes acidotic. In type 2, there is a failure to reabsorb bicarbonate. As a result, the blood becomes acidotic. Type 3 is a combination of 1 and 2. So a failure to excrete hydrogen and a failure to reabsorb bicarbonate. So again, that results in acidemia. Type 4 is a different mechanism related to aldosterone deficiency. As a result, a patient has Addisonian bloods with a high potassium, high hydrogen ions. Type 1 is a distal tubules are affected, and type 2 proximal tubules are affected, and type 3 both distal and proximal tubules are affected. So let's talk a little bit about type 1. Type 1, as we mentioned, is the inability to secrete hydrogen ions. The problem is with the apical hydrogen-potassium antiporter of the alpha intercalated cells, which becomes dysfunctional. These cells are seen in the distal nephron and the collecting ducts, and they're there to secrete hydrogen ions and reclaim potassium. When these are defective, you have hypokalemia and you have increased hydrogen ions leading to severe acidosis. The urine is unable to be acidified, and so the pH tends to be relatively elevated. Now, calcium phosphate stones tend to deposit at higher urinary pH levels, and therefore in type 1 renal tubular acidosis, patients present frequently with calcium phosphate stones, and these can be bilateral. Note that in both type 1 and type 2 renal tubular acidosis, potassium will be low. The treatment is with bicarbonate to mop up the excess hydrogen ions. Type 2, which is a proximal tubulopathy, which results in the lack of absorption of bicarbonate in the proximal tubule, i.e. a bicarbonate leak, results in acidosis. Note that the distal alpha intercalated cells are functioning normally in this condition, and so acidemia is less severe. The way to diagnose this is the fractional excretion of bicarbonate is high, more than 15%, but again patients will present with hypokalemia, and the treatment is with high-dose bicarbonate. Now, because this is a proximal tubulopathy, type 2 renal tubular acidosis gives rise to a number of other manifestations. The proximal tubules, you'll recall, are involved in regulation and reabsorption of many important factors, including phosphate, glucose, amino acids, uric acid, as well as proteins. So if these are defective, and you end up with phosphate urea, glycosuria, amino acid urea, uricosuria, and tubular proteinuria, this results in deficiencies leading to Fanconi syndrome, which results in poor bone mineralization, as well as osteomalacia and rickets. Type 3 is a combination of type 1 and type 2. Type 4, we mentioned, is a different mechanism, results from aldosterone deficiency, and therefore not strictly a tubular disorder, occurs as a resultant consequence of adrenal failure with a mild acidemia. The patients will be hyperkalemic and likely hyponatremic, and treatment is with fludrocortisone. Treat and determine the underlying endocrinopathy or cause, and calcium resonium may be required to treat the potassium, albeit hyperkalemia is a medical emergency and would require emergent management. Now let's discuss some causes that would result in alkalosis rather than acidosis. There are 3 key conditions that you should be aware of: Bartter's disease, Gitelman's, and Liddle's. These are all genetic conditions that result in hypokalemia and metabolic alkalosis. Bartter's and Gitelman's tend to cause normotension or hypotension, whereas Liddle's causes hypertension. Bartter syndrome causes hypercalciuria, whereas Gitelman causes hypocalciuria. Gitelman's causes hypomagnesemia. Remember that both Bartter's and Gitelman's are autosomal recessive conditions, whereas Liddle's is autosomal dominant. In Bartter's and Gitelman's, there's a secondary hyperaldosteronism, and in Liddle's, there is hypoaldosteronism. What we'll do now is just individually separate these three conditions, just so we have a good understanding. In Bartter's syndrome, the defect is in the sodium-potassium chloride transporter. And this is in the thick ascending loop of Henry, essentially where loop diuretic acts. So the findings are similar to those as you'd find with loop diuretics. It's a salt wasting disease, so you have hyponatremia, you have increased calcium excretion, so hypocalcemia or hypercalciuria, and mild hypomagnesemia. Whereas Gitelman's acts on the distal convoluted tubule and behaves like thiazide diuretics. And the defect is in the sodium chloride cotransporter, resulting in hypocalciuria and hypomagnesemia. And the patient may be consequently hypercalcemic. Liddle's, as we mentioned, results in hypertension and low renin-aldosteronism, and the patient would be hypokalemic with a metabolic alkalosis. Thank you for attending this medicine masterclass.